ఇట్రా లాస్ట్ ఏమైంది
ఇప్పుడే ఈ క్లాస్
చెప్పంగానే రాస్తే అయిపోతుంది కదా నువ్వు.
A very good morning to one and all. I heartily welcome to the second day webinar. I request all the participants to kindly wait for another 5 minutes so that the rest of the participants can join the meeting immediately. If you have friends and your colleagues who have not joined the meeting, kindly inform them to join the meeting immediately so that we can start the meeting without any delay. The speaker for today, Mr. Shushanta Sir Das, has already joined the meeting. So the speaker is already ready with his presentation today. So kindly I request all the participants to inform your friends and colleagues to join the meeting immediately. Thank you.
Roshan sir, will you please share the link in teaching group?
They can join with the same link, ma'am.
Yeah, but still people are texting.
Yeah, I am sharing. Good morning, everyone. The meeting link has been shared to your in your chat box. You can copy that link and share to your friends and immediately ask them to join the meeting. Thank you. We have right now 115 participants overall. So we'll be starting the meeting exactly in another 3 minutes. I request today moderator, Dr. Chandana ma'am, to just be ready with her things. Thank you.
Roshan sir, Dr. Chandana ma'am has not joined, I think.
No, she's there. She's there, ma'am. Don't worry.
I'm ready, sir. I was muted. I didn't check.
So good morning all. I now hand over the session to Dr. Chandana ma'am to start the session.
Very good morning to one and all. Thank you, Mr. Roshan. I welcome you back. I welcome all the participants, today's eminent speaker, the committee members, HODs, faculty, principal sir, and all the participants from various colleges, from various states. We are really pleased to organize this meeting. Before I start today's second day session of the 2-day webinar program on present day drift in pharmacy practice organized by CMR College of Pharmacy. I take the privilege of introducing one of the most experienced person in Pharm.D course. So today's eminent speaker is Mr. Sushant Kumar Das sir. Mr. Sushant Kumar Das has completed his B.Pharm from University of North Bengal in 2002, M.Pharm in Pharmacy Practice from JSS College of Pharmacy, Ooty 2006, pursuing doctorate from Sumandeep Vidyapeeth. A total of 14 years of experience sir is having in teaching and 2 years of Pharm.D marketing experience. So, sir is in this Pharm.D profession right from the inception of Pharm.D in India in 2008 at JSS College of Pharmacy, Ooty, associated with the Pharm.D course. Currently, sir is working as Associate Professor and Pharm.D Coordinator at CMR College of Pharmacy, Hyderabad. Sir has to his credit more than 35 research publications in national and international journals, including indexation in UGC, Scopus, Web of Science. And sir has more than 50 poster presentations in national and international conferences. Sir has carried out research work in various areas of healthcare for B.Pharm, Pharm.D, and for M.Pharm students. Sir is actively associated with various social and extracurricular activities like blood donation, medical camp, awareness rallies, and others. His field of research interests include type 2 diabetes mellitus, drug utilization, review, and drug-related problems. So above all, I am fortunate enough to learn about this hospital training and more about Pharm.D projects under the guidance of Mr. Sushant Kumar Das. Sir is a very good teacher. He can explain anything, though you are like, if I don't have any knowledge of Pharm.D, then also he can explain many higher concepts of teaching. So that is the speciality of Mr. Sushant Kumar Das. We are really pleased to have you here, sir. And I wish all the participants a very happy learning today. With this, may I hand over to Mr. Sushant Kumar Das.
A very good morning, and thank you, Dr. Chandana, for your generous introduction. It was really a pleasure to hear from you. Thank you. And on the outset, I would like to thank the management, college, principal, sir, all the HODs, our other colleagues for organizing this beautiful 2 days webinar on current drift in the pharmacy practice, as we are seeing that post-COVID-19 situation, healthcare is going to be the next gen situation. People are looking into the healthcare aspects from every corner. We may not be looking into the entertainment or any other thing, but we are looking into the healthcare scenario, how the situation, how the things can be improved further, and how we can live properly in a beautiful world. So taking all this scenario into our understanding, I thought we'll discuss about the pharmacy practice and its current scenario in India. Yesterday, Dr. Sadaghoban has explained in brief and in details about the current scenario of Indian pharmacy practice scenario, how the hospital training should be, what are the international asking, how we should match with the international standards. Taking those points into consideration, I thought I'll take this opportunity to go a little bit in depth about the hospital training. The word Pharm.D may be there, may not be there, but the word is hospital training with a clinical pharmacy practice. How hospital training can be a bridge to provide better patient outcome. That I thought I'll discuss with all the participants in today's discussion. So thank you everyone for providing me this opportunity. I would like to continue. Next slide, please. So first of all, this is the introduction to ourselves. We are at CMR College of Pharmacy, Hyderabad, one of the renowned pharmaceutical institution in Hyderabad. We have our B.Pharm, we have our M.Pharm, as well as our Pharm.D. Next slide, please. This is the hospital with which we are associated. We are associated with Gandhi Hospital. Gandhi Hospital is one of the largest renowned multi-super specialty government hospital in the Telangana state. It has almost all the departments with large number of specialists available over there. We are lucky enough to be associated with Gandhi Hospital to train our Pharm.D students, and also we are lucky enough to gain sufficient and elaborate knowledge about the patient and disease and drug from the Gandhi Hospital. Next slide, please. This is what I thought I will show first, what we do actually, whether we are really there or not. Yes, we are there. We are there in the hospital. We are there inside the hospital. We are there inside the ward. We are there beside the patient. So this is a clear picture what we do actually. We provide bedside training to our students, as well as we provide bedside service to the patient. The actual meaning of clinical, when it was introduced in 1960s in the Australia, the word clinical was mainly bedside, because before that, if we look into all the pharmacy setup and pharmacy activities, everything is mainly focusing the patient, but nobody is there beside the patient to see whether the drug is really working or the drug is showing any side effects or adverse effect, or there is any other complications. Whether we see industrial pharmacist, whether we talk about community pharmacist, we talk about hospital pharmacists who are there in dispensing as well as preparation, everyone is focusing, academicians who are in pharmacy, everyone is focusing for patient care, but hardly anyone is there beside the patient to see what is the actual drug effect. From that, the term clinical introduced. Australia is the first country to take this concept, introducing pharmacy students into the direct hospital, round hospital, and providing them training to improve the patient outcome. From there, the concept of clinical has changed from bedside to the human being. So anything which is related to human being is present day considered as clinical. So if we say clinical pharmacy, this is a concept which is directly related to the human being. Here we'll consider as patient. What exactly happening with a drug in the patient to observe, to monitor, to identify, to report, to overcome, and provide a solution. All this comes together as clinical pharmacy. Next slide, please. This is a outline what we do actually for the Pharm.D hospital training. If we see, there is second year, third year, fourth year, fifth year, and sixth year in which students go to the hospital. In the second year, students go only for the pharmacotherapeutic subject as a practical. In third year also, pharmacotherapeutics 2, the subject for the practical. In fourth year, they have 3 subjects, pharmacotherapeutics 3, hospital pharmacy, as well as clinical pharmacy. In the fifth year, there is clerkship and project. And in the sixth year, there is internship. So if we look into the training module, this has been categorically made in such a way that students can gain their knowledge, understanding, and can develop their practice in an appropriate manner. So what we are finding in the second year and in the third year, there is minimal clinical activities, and the students get understanding about hospital, case, various tests, diagnosis process, as well as the drug prescribed. Because in the second year and third year, once they are going at the initial stage to the hospital, they are not at all aware what is going to happen, how the things are to be done in the hospital. Because before that, someone might have went to the hospital, but they went as a patient or to see some patient. But this is the first time someone is going to hospital as an academic or for some academic purpose. So this is an entirely different scenario. The student has to understanding first, what is a hospital? What are the different departments? Where the patient gets admitted? What is an OPD? How the patients are being segregated based on their condition? What is a case? What are the points kept on a case? What are the points need to be understand from a case? What are the various tests are being done? What are the various diagnostic tests are done based on patient's condition? And finally, once the diagnosis is confirmed, what a drug is being prescribed. In this situation, I'd like to say, if we see in the second year, we have studied about myocardial infarction. If we see in the clinically, in the theory, myocardial infarction, the clinical feature, it denotes as patient has a pounding pain in the chest on the left sternum. The pain radiates to the left shoulder, to the neck, and it goes to the backside. Along with that, there is profuse sweating and shortness of breath. Frankly speaking, if we see the patient, no such complaint patient can experience or patient can explain that I have a radiating pain. This is only a theory. Patient will put his hand into the chest and will cry, shout, creep, or patient may be unconscious. So first we have to understand what are the situation really develops in the patient what we have studied in the theory. So that is the first understanding. Next slide, please. Now, once the student go to the fourth year, they have 3 subjects and they have description about pharmacotherapeutics 3. They have hospital pharmacy as well as they have clinical pharmacy. At this particular juncture, student will get some in-depth understanding about patient, also start interaction with doctor and patient. So from the fourth year, students should start slow interaction with the doctor as well as with the patient. Why I'm not asking for the second and third year? Because in second and third year, they are still on the theory. They are not completely adapted with the theory to interact with a doctor or to provide information to the patient. So from the fourth year, they should start interaction with the patient as well as doctor, definitely under the guidance of the preceptor. Also start interaction, and this provide an opportunity for further strengthening the relationship in the hospital with other healthcare professional for upcoming years. Why? Because fifth year as well as sixth year are 2 more years where student has to spend more times in the hospital, more they have to interact with the doctor, they have to provide clinical pharmacy service, as well as they have to gain more knowledge from the hospital training. So fourth year is the main platform from where they should start interact, they should start have a mingling with the other healthcare professional so that they can get an in-depth understanding. Now, once the student is there in the fifth year, they must interact with the doctors and other healthcare professionals and patients on a regular basis. And they should provide various clinical pharmacy service. We'll come into this point. Also, they must carry out a project in association with the doctors. So if we see from the fifth year, actually the student has to get the clear, in-depth and very specific understanding about the interaction with the doctor, about interaction with the patient, as well as they should apply the knowledge what they have gained in their second year, third year, fourth year theory subjects into the real practice scenario. In the fourth year, they have a subject like clinical pharmacy. In the clinical pharmacy, they have theoretical points like drug information, drug-drug interaction, adverse drug reaction, drug-related problem or medication error, as well as drug-food interaction and patient counseling. Now, once they are in the fifth year, they have to apply all these theoretical knowledge into a very practical practice that is known as clinical pharmacy practice. They have to apply all this into a practice to get a better patient outcome, to mingle with the other healthcare professional, to establish themselves as a part of the healthcare team, as well as they have to carry out a project in association with the doctors. Next slide, please. Now, in the fifth year, the first and foremost hospital training comes up as a clerkship. There is a doubt, what does this mean actually, clerkship? If we see the actual meaning of clerkship is nothing but documentation, right? The clerk, what is the role of a clerk in an office? They have to maintain all the files in an appropriate manner so that whenever they are being asked to provide, they can provide them in an appropriate manner. That's what it has been considered like all other practicals where you can have a producible evidence. Like if you say, I have done a pharmacognosy practical. So you have done some transverse section, you have taken the slide under the microscope, you have a picture. So you have an evidence to show someone. Then if you say, I have a chemistry practical. So you have done some assay, you got the result, and you have an evidence to show. Then if you say, I have a pharmacology practical, and you have an evidence. But if I say you, have you provided patient counseling? You will say, yes, I have provided. But my next question will be, how can you provide that evidence, yes, you have provided a patient counseling. So here comes the most important part of the clerkship, documentation. Whatever you do, you must document them. You must keep them in an appropriate manner, in a reproducible manner. You must keep them in an appropriate manner, in a reproducible manner, so that whenever anybody asks whether you have done this particular action, so you should be in a position to take out those forms and formats and documents to produce in front of them to show that, yes, I have done this particular activity. So that's the main thing about the clerkship. It's not only doing, it's also documenting. So in the clerkship, students should participate in regular ward rounds, analyze the prescription, and communicate with the doctor regarding therapeutic issues. So you need to be there in the hospital. You need to be there in the ward rounds. You need to check each and every prescription for each and every patient. It should not be random. It should not be, I wish, I like my choice. I will take only this patient. I will take that patient. No, you should see each and every patient. You should see whether the drug has been prescribed accordingly. You should see whether the patient complains and the diagnosis and the drugs are matching or not. If you find that it's not appropriate, then you should refer them, cross-check them with a standard reference, as well as you, with the proper discussion with the preceptor, you should go back to the doctor and report them. Dear doctor, you have prescribed this one. I've gone through the reference. I have cross-checked with the standard reference, and this is my finding. Would you like to see a double check? So that should be your approach. If doctor is ready to accept your point, take a note of that, document them, and keep it along with you, so that if any such situation develops later, you are in a position to provide them, to show them again. So if needed, the student must be in a position to provide suitable solution to therapeutic issues also. So our situation as a clinical pharmacist, what we are there in the hospital, it may be in a M.Pharm situation, in a Pharm.D situation, or in any other training when there is a pharmacist in a hospital inside the ward, interacting with the patient as well as with the doctor, they must be in a position to provide a solution. We are not there only to find the mistake. There are so many situations where people can find mistake on each other. We are not there to find a solution only. We are not there to find a mistake only. We are there to find a solution so that patient can get a better outcome. Please make sure this should be our aim. This should be our target. We are not there to compete with anyone. We are not there to criticize anyone. We are not there to find anyone's mistake. We are not there to find negative. We are there to find a proper solution so that patient can get a better outcome. Ultimately, we will also be considered as a part of the healthcare team. Next, the simultaneously, student must interact with patients to get, continue on this one, please. Simultaneously, student must interact with patients to get information about their past medication and other relevant information, so as to provide appropriate suggestion to patients about their drug therapy. Right? Here comes a situation why we need to get all those information from the patient directly, where we can get all those information on the case sheet. But you must not rely on the case sheet completely, because patient may say some lies to the doctor at the beginning, patient may hide some information, or patient may exacerbate some information once they are talking to the doctor. So it should be the role of a clinical pharmacist to go beside the patient's bed, as we have shown in the first picture. You should be there beside the patient's bed. You should make the patient comfortable with your talk. You should interact with the patient in a very cool and casual manner, so that you can get maximum information from the patient. You should cross-match them along with the patient's case sheet, whether patient is giving you the appropriate information or still there is any mismatching in the information. Only if you can get the appropriate information from the patient, you can prepare an appropriate therapeutic strategy, counseling strategy, drug information strategy, drug counseling strategy, and all others. Next slide, please. and the project in the 5th year. What is the importance of a project in the 5th year? And what is the importance of a 6th year, 6 months project in the 5th year, right? We have a 6 months project in the 5th year. The 6-month project is mainly considered as a observational data collection study. And it should be carried out in the hospital. It should be carried out in association with the doctors, specifically looking into a disease and their outcome, right? Specifically about a disease and their outcome. So till the 4th year, we have studied pharmacotherapeutics 1, pharmacotherapeutics 2, pharmacotherapeutics 3, and we have almost covered around 50 to 60 diseases which are generally available or present in the hospital. So from there, we have to pick up one particular disease. Also consider that fever is a very simple thing and oncology is a very important thing. No such thing. Please remove such ideas from your mind. Every condition is important. Once a patient has got admitted into the hospital, that means it's a serious issue. That means it's a serious issue, and we should look into each and every case with the same seriousness so that we can provide appropriate strategy for each and every case. Then the project must be done in association with doctors in a view of various disease and their outcome. Project will give a clear idea about management strategy, how a disease is being managed. Till now, we have studied that a disease can be managed with drug, without drug also. Like if you say the chronic diseases cannot be treated only with the medication. The very simple thing which we are talking about, diabetes. The India has become almost a diabetic capital in India, right? Every household has a diabetes. Like every household has a fridge, TV, car, scooter, AC, washing machine, and also a diabetes. So it's becoming a healthcare burden for each and every household. Diabetes has expense, diabetes has restrictions, diabetes has complications that leads to death also. So we have to understand how the management about those chronic diseases can be provided. It has been considered with the food restrictions, with having some exercise, diabetes can be controlled. Only drug alone cannot help. So we have to understand this type of strategy, and we have to work on the project with the data collection, and we have to provide an appropriate solution. It may not be a society changing with a 6 month, but this may be a step. This may be a step. In future, if you really work on a research work, or if you are working in a research institute, whatever you have learned in your 5th year project will be your platform for your further study. And this is important to learn specific points about a disease which may not be able to learn through theory only. So we have learned something in theory that is only theoretical. You can see a single diagnosis or conformational diagnosis. Let us consider hypertension. We say hey, it's only a 3-word disease, HTN. What is there? Let's consider it is there with the male and female. There is an age gap difference. In our last study, if I am not wrong, 2 years back, we were working on Gandhi Hospital on a hypertension study, and the least age we have found 35. In the textbook, it has been mentioned mid-40s, but we have found patient with 35 as the least age where hypertension has developed. So this is a new finding. Once you are doing a study about a particular disease, you get patient. There is female, there is various age, there is ethnic group difference, there is food habit difference, there is past medical history, medication history, there may be family history, may not be family history, there may be some other comorbidities, or there may be some other clinical or non-clinical issues. So only with the diagnosis, we must not come to a conclusion that this is going to be like this. No, there will be various data, there will be various different issues for the development of one disease. So with this type of project, which is observational data collection, we should be focused only to see how a disease is developing and what are the management strategy can be adopted for this particular disease. Next slide, please. And the last one is the internship, where a student will spend 6th year of the Pharm.D in hospital, 1 whole year hospital training. In that 6 months will be there in the general medicine, and 2 months of 3 roster will be there from another departments like orthopedic, gynecology, pediatrics, psychiatrics, skin and body, and general surgery. And in internship, students should participate in regular ward round and perform various clinical pharmacist activities with the main aim as better patient outcome. Now we'll come to the actual practice scenario. Next slide, please. Now, yesterday there was a discussion and there was a point like, what are the areas where clinical pharmacists can be introduced themselves in the patient-centric healthcare model, right? What we can do, because there are so many pharmacists, or I can say so specialist pharmacists available in the existing system or in the existing model. There is industrial pharmacist, there is community pharmacist, there is hospital pharmacist, and so on, right? Academicians are also pharmacists, and so on. There are various areas where pharmacists are available. But if we see very frankly, none of these pharmacists are patient-centric into the direct patient care model. None of them. Everyone is working for the patient care only. Definitely, everyone is working for the patient. The person, the research pharmacist who is working on a transdermal drug delivery system or targeted drug delivery system, they are also targeting to improve the better patient care. The hospital pharmacist who is dispensing, he or she is making sure that appropriate drug reaches to the correct patient. So in this situation, how a pharmacist can fit into the healthcare model. So here is the point, what we can do, how we can go directly into the patient care model, and how we can establish our role. There are so many points which can be there, but amongst them, from my practice scenario for last, I can say 16 years for my last 16-year hospital training, learning, practice, what I have seen, there are situations like pharmacoeconomic model, pharmacodynamic model, epidemiology model, and so many others. But amongst them, what I find, these 5 important points, which are most important to establish ourselves as a part of the healthcare team, to integrate ourselves as a healthcare team, healthcare member, and we can also be a part in the patient-centric model. The first one is patient counseling. The second one is drug and therapeutic information service. Third one is adverse drug reactions identification and reporting. Fourth one is drug and drug food interactions identification and reporting. The fifth one is drug-related problems identification and reporting. There are many, like pharmacoeconomic study. But if you are talking about a government hospital where the drug is being provided free of cost, pharmacoeconomic study will not be suitable in that particular. That is one situation. Pharmacokinetic model to develop a dosage regimen. We need a HPLC, we need expertise, and that is expensive. For all the patient, it may not be a possible situation to bear the cost. So there are other like antibiotic stewardship, fellowship in a specific ward, and all other. So from this is my personal experience. I feel we should initiate our practice, we should initiate our activities in these 5 most accepted clinical pharmacist service scenario, so that people can realize us, people can accept us, people can understand our service, and ultimately we can provide a better patient care. Next slide, please. Right. So what is patient counseling? We consider this is a very simple service. Nothing is there. Just go beside the patient, just go and say a few words and come back. But reality is entirely different, right? We feel patient know everything and they will manage their medication. But we hardly realize how, right? We hardly realize how. Let's consider a very simple counseling point about proton pump inhibitor. Pantoprazole is one of the most common prescribed drug in today's scenario. Pan-40 or even pantoprazole with domperidone, Pharm.D is the drug which has been prescribed widely, almost in all prescriptions. If there is no ranitidine, pantoprazole is definitely there. So a simple counseling point, very simple counseling point, take this medication, take this drug immediately after you wake up and brush, take this drug, take some break of around half an hour, then only you go for your breakfast. So every day morning, before eating anything, take this drug. So that should be your counseling. You should not say very technical terminology. You should not use medical terminology. Instead of supporting the patient, you will scare the patient. So you use very simple terminology. Whatever language is comfortable with the patient, try to use that language. Whatever manner it is easy for the patient, use that manner, right? I'll not describe what should be the patient counseling procedure that you have studied in the theory. You should introduce yourself, you should make the patient sit, you should counsel, you should close the session, you should ask the patient what you have learned from me. I don't want to say all those things. I want to say how we can be a part in the patient care, how patient can really realize us, accept us, and find that yes, this clinical pharmacist can improve my health outcome. If you say, take this medication only in the morning after your brush, before the breakfast, take some half an hour gap. The drug will act better. The drug will act better. If the patient takes this drug after the food, even though the drug is prescribed rationally, due to the administration error or due to the timings error, the drug will not act in that way what it's supposed to be there. So there will be a ineffectiveness, therapeutic failure, therapeutic burden, economic burden, health outcome will be poor. Similarly, the statin, another most common prescribed drugs in present day scenario, because people are developing more and more cardiovascular diseases, CAD. Whenever there is a cardiovascular disease, there is a statin prescription. So what we have studied in theory, statin works better in an acidic environment. So when is the acidic environment? In the midnight scenario. So what we can say, take this drug at bedtime. In Latin terminology, it's considered as HS or horasomni. You might have seen that statin is also prescribed as ODHS. So once a day, horasomni means at bedtime, only once a day at bedtime. So if you say this word to the patient, take this medication only at bedtime, simple, just 3 words, only at bedtime. If the patient takes that drug only at bedtime, during the night, due to excess acid secretion, the statin get more absorbed and it gives a better effectiveness. So it's simple 3 words. With simple 3 words, we can enhance better patient outcome. We can enhance better patient outcome. So that is the importance of patient counseling. And this is one of the most important part as a clinical pharmacist, being there in hospital, we should play, which is non-invasive, which is not going to cost any harm to anyone. Instead, it's going to improve the outcome. And furthermore, if you counsel about the do's and don'ts, especially for the chronic disease, especially if you say diabetes mellitus, that there is a concept that is known as KAP, knowledge, attitude, practice. Only if the patient has a proper knowledge about the disease, then only the patient will have a proper attitude and patient will practice. Like we have the word SMBG, self-monitoring blood glucose. Until and unless someone makes sure that explain the process about self-monitoring blood glucose to the patient, that you just take a blood drop, put it into that glucometer, note down your blood sugar on a small diary. Maybe once in a week, once you are going to the doctor, carry your diary to the doctor and show it to the doctor. So that's a self-monitoring blood glucose. If the patient has a proper knowledge, then only patient will have that attitude towards the disease and will practice accordingly. There will be a 4 blood sugar report in a month. And if the patient is going to the doctor every 3 months, so there will be a 12 report with the patient. Once patient will go to the doctor, doctor will have a very clear idea what the patient's blood sugar condition for last 3 months. The same, this very minimal practice can be performed sitting in the home only. So as a clinical pharmacist, if we provide these do's and don'ts, especially for the chronic disease, it improves patients' perception about the clinical condition and increase better attitude that leads to a better outcome. Next slide, please. Hello, Roshan sir.
Yes, sir. Drug therapeutic service.
Right, thank you. Right. The second one is drug and therapeutic information service, right? Information. Today's world works on information, right? The world works on information. Everybody needs information, whether it's a purchase of a pin or it's a purchase of a rocket. For everything, we need information. We rely on information. You want to purchase a soap, you want to see what type of information is there on the TV as advertisement, that which soap is good. You want to purchase a motorcycle, you want to rely on the information. Now, if you want to purchase the medicine, are you relying on the information? Is anyone providing you any information? The answer is hardly no. Whenever someone is needed for an information about a drug or a therapeutic, where to go, whom to ask? This is a question which is there always, right? In India, if we say there are more than 15,000 generic molecule and more than 85,000 brand medicine is available, right? Like generic mean, if we say paracetamol, the most common word which comes in our mind is paracetamol, right? That's a generic. And if you say brand, there is Crocin, there is Parasip, right? There is Imol, and like that, there is so many brands on a single generic. So there are almost 85,000 brands with 15,000 generic molecules. It's practically impossible for any doctor to remember and recall all those at any given point of time. It's highly impossible, and it's not supposed to be. No one is supposed to remember 85,000 brand at the time of patient care and recall and write that. No, not necessarily. So what we can do, right? What we can do? The doctors, what they will do? They will ask the pharma sales representative or whoever is available to provide the information. Once a pharma sales representative is interacting with a doctor, doctor is asking, I need this information. The sales representative will go back to his company and will seek the information. They'll provide information. Yes, they will provide information. No doubt, they'll provide information, but they will also keep the profit of company in their information service, right? Here comes the conflict of interest, right? Next slide, please. Right. Here comes the role of clinical pharmacists who are appropriately trained to provide unbiased, appropriate, patient-specific drug information, right? Which definitely improve not only the drug knowledge, but helps to pinpoint patient-specific therapy, right? Furthermore, how the drug information service or drug and therapeutic information service, like patient-specific conditions like pediatric, right? As we have seen, pediatric dose adjustment calculation is very important because based on the body weight, minor ups and downs in the dose may cause fatality, right? Geriatric, as the age goes above 65 and more, the liver, the kidney function deteriorates. So if you give a higher dose, which is been given to a normal adult, the drug may not be completely metabolized or the drug may not be completely excreted from the body. Instead, it get accumulated, leading to a toxic level and may cause complications, right? Furthermore, if the patient is having a hepatic or renal insufficiency, in a patient has hepatic or renal insufficiency, or if the patient is on polypharmacy, or if the patient has multiple comorbidity, right? If the patient has multiple comorbidity, in such situation, how to choose a drug, how to choose a dose, what should be the schedule, what should be the regimen, how it should be kept a gap with another drug, what should be the drug appropriately for that particular condition. At that moment of patient care, the doctor may not have a time or may not have a situation to recall what he has studied and how many drugs are there, from which what should be the dose adjustment. So if a clinical pharmacist is available along with the doctor in the hospital, doctor may have asked the clinical pharmacist, provide me this information, take this time, get back to me, maybe 1 hour, maybe 2 hours, maybe 1 day, or maybe within a week, right? Maybe within a week, but provide me this particular information so that I can handle this patient in an appropriate manner. So if the clinical pharmacist take this as a appropriate manner, because they have studied these things, drug information service, this we have drug information service, we have studied. In the 4th year clinical pharmacy, there is a big chapter, drug information service, right? How to get a drug information query, how to search the query, how to formulate the answer, how to respond, and how to document. So we have studied this one. What are the resources we have studied? How to find a suitable solution for a patient specific condition. We have studied all these things. Now this is the time where they should and must implement the theory into a practice scenario for a direct patient care. Ultimately, appropriate drug selection with proper knowledge definitely improve patient outcome and reduce therapeutic burden and economic burden. I still remember orthopedic HOD. I still remember orthopedic HOD in Gandhi Hospital. He was discussing with us like gentamicin is one of the most common drug which has been prescribed in the orthopedic situation, in the orthopedic surgical procedures. The doctor and gentamicin has been even prescribed for 21 days also. Gentamicin has been prescribed for 21 days also. So he has prescribed. After a few days, patient came with doctor, I'm finding a typical sound in my ear. I'm finding a typical sound in my ear. So we have studied that aminoglycosides are supposed to cause ototoxicity. So if somebody would have provided this information, then this condition might have been resolved earlier. So if now the patient is having a ototoxicity, so that's a therapeutic burden as well as an economic burden. Furthermore, one patient has got severe renal insufficiency with the gentamicin, because we have found that gentamicin is also supposed to cause nephrotoxicity. So if a patient is on a gentamicin, you can just go and ask the doctor, dear doctor, in every week, just go for a renal function test. Simple, just go for a RFT. Check the urea, BUN, and creatinine. If you are seeing that it's going up, then you can adjust the dose. So with a very simple, appropriate, patient-specific, unbiased information, the outcome is very high, where patient will get a better outcome without having much complications. Next slide, please. And this we know that there are 3 main resources available for the drug information: primary, secondary, and tertiary, the textbooks, the standard journals, the analysis, the meta-analysis and reviews and all. So we have all these resources available with us in every college, every hospital. We have textbooks, we have standard textbooks, we have journals, we have websites also. We have websites like drugs.com. They use Micromedex as their software. The rxlist.com, they also this drugs.com, rxlist.com, they use IBM technology, they use Cochrane database, they use Micromedex. So these are very simple, very free, easily accessible. Just put your search into the search column. You will get the detailed description, patient wise, age wise, condition wise, indication wise. So just get the information, go back to the doctor, provide the information so that the patient who needs this one to get a proper drug therapy can get a better outcome. With proper response to drug information queries, clinical pharmacists can certainly become an integral part of healthcare team, as information is everything. Next slide, please. Now, the most important thing, adverse drug reactions. This is the word nowadays people are talking, right? If you see in the profession, the pharmacovigilance, the word pharmacovigilance. See, you can see in the latest scenario, hydroxychloroquine, right? Hydroxychloroquine is the word which is being discussed by everyone, even if people don't know who is Cristiano Ronaldo or CR7, but people know what is hydroxychloroquine. If people is not able to say what is hydroxychloroquine, at least they are able to say what is HCQ, right? So this is the situation. Why we are aware about this particular hydroxychloroquine is a drug with serious cardiotoxicity, right? Once it has been approved, once it has been withdrawn. Again, it has been said it is okay. Again, it has been showing that it's showing complications. So everything is only documented based on the instruction and report, right? This is the most important area. Every clinical pharmacist should keep an watchful eye during training. To be very frank, right, what I have seen with my personal experience with the doctors, they are aware about that. They are absolutely aware. Time constants, they are unable to report the same, right? The word and keeping a close eye on every patient and watching development of any untoward reaction, should monitor them closely with proper reference and must discuss with the visiting doctor to confirm any such reaction. So as the clinical pharmacists are there in the ward for long duration. So in association with the nurses, they are also there in the ward. Nurses are the one who will be there in the ward 24/7. Doctor may be there, may not be there. Clinical pharmacist may be there, may not be there, but nurses are always there. So make sure you will gain or you will get appropriate information about the patient from the nurses. So interact with them, have a collaboration with them, try to get what actually happened to this particular patient so that you can get a clear idea about the patient. Next slide, please. Right. The adverse drug reaction even may lead to serious complication, including death, right? Hence, a close observation, identification, reporting, and suggestions for suitable alternate. Again, my point is, we only must not find the complaint or we only must not find the problem. We have to provide a suitable alternate or suggestion. If you really want to establish yourself as a clinical pharmacist, as a part of healthcare member, as a patient-centric model, as a part of patient-centric model, you need to provide a suitable solution. Until and unless you provide a suitable solution, nobody is going to accept you into the healthcare model. Problem identification can be done anyone. A layman also can identify a problem. Until and unless you are providing a solution, nobody is bothered about you. Nobody will care about you, right? So what we should do, right? Not only during hospitalization, even post-discharge medication may also cause ADR, and a proper count, a very simple situation with the oral hematinics, right? Oral hematinics, ferrous sulfate. Ferrous sulfate, what we have found, it has a adverse reaction or side effects, like it will cause constipation as well as black color stool. So if the patient has not been counseled that you will have a dark color stool or a red color stool, the patient will get scared by seeing the stool, will feel that blood is coming out, or patient will have a constipation that will lead to discontinuation of the medicine. So what you can say, it may give you a constipation, but it is good for your blood improvement. What you can do, have some additional or extra water at the night time. You may need to go to washroom once in the night, but that will help you to have a good motion in the morning. Having a constipation or having a midnight urination, if you compare, midnight urination will be accepted than having a constipation in the morning. And if you provide that counseling, it may give you a red color stool. If you stop the medicine, once you will stop the medicine, the red color stool will go away. So if you give this counseling, the patient will accept it, patient will get it in a positive way, may not discontinue the drug, and the therapeutic outcome will be more. So here is the part where we can play our role. So therefore, role of clinical pharmacist is significant important in this area. Next slide, please. Right. Even we are talking about adverse drug reaction, even government has taken sufficient step regarding the voluntary reporting of ADR. Previously, CDSCO, Central Drug Standard Control Organization, was the premier organization in India who used to request the healthcare professional or anyone to report voluntary adverse drug reaction. Now it has came under the government of India, Ministry of Health and Family Welfare, and that one part of that is Indian Pharmacopoeia Commission, which is there at the Ghaziabad. They have came out with a program that is known as Pharmacovigilance Program of India, under which even Pharm.Ds are getting recruited, right? I have seen so many of my students has got recruited as a technical associate, okay, drug safety associate in the institutions where large number of patients are getting admitted, right? This is a specific government job specific for the Pharm.Ds, right? This is specific for the, and even if you can remember in the month of January in Telangana, there was a case like after giving the after giving the vaccinations, the child's develop fever, and paracetamol was supposed to given to them. But instead of paracetamol, someone, I don't want to blame anyone, right? Someone has powdered the tramadol tablet. It looks same, right? It looks same. Has powdered the tramadol tablet and mixed it and has been given to the all those infants, and 47 infants developed seizure and shortness of breath, and unfortunately one baby died, right? So that was another situation which government has taken seriously, and they have come out with a new program that is known as adverse events following immunization. On Gandhi Hospital, the inauguration program, I was also there. They've described what was the mistake over there, and what the solution they have provided. They have given the solution. Next on, after any vaccination, whenever there is a fever, only paracetamol syrup from the bottle should be administered, right? Only paracetamol from the bottle should be administered. No tablet, no other, nothing, no injection, no tablet, only paracetamol syrup from the bottle should be administered. So that is the solution they have given. They have learned from their mistake and from a fatality, right? So as a Pharm.D, as a hospital pharmacist, as a clinical pharmacist, or anyone who is there in the hospital to provide a clinical support to the patient should understand this concept, provide appropriate solution regarding adverse drug reaction. And students who are interested in the field of pharmacovigilance, this is one of the highly booming field in the healthcare scenario, as their profession should gain proper knowledge during their internship about adverse drug reaction. Next slide, please. Right. And this is also one of the most important service which clinical pharmacists should come forward to provide to the doctors, or even to the nurses, or even to the patients, right? With polypharmacy, right? When there is more than 5, 6, 7, 8, 9, 10 drugs in a single prescription, is always there is a chance of development of drug-drug interaction. And it may not be possible to reduce the number of drugs based on the patient condition. Patient may be geriatrics, patient may have multiple complications, patient may have other underlying situation for which they need a multiple drug or a polypharmacy, right? So hence a proper therapeutic plan become necessary. So clinical pharmacist with adequate drug knowledge can play her or his role to prepare an individualized drug schedule plan so as to keep appropriate gap between multiple interacting drugs. So if you are seeing that two drugs, both are administered OD once a day, and both the drugs have a interaction. So you have that opportunity to keep a time gap, one drug to be kept in the morning, another drug to be kept in the afternoon or in the evening. So you need not to reduce the number of drugs, but you can plan in such a way you are keeping an appropriate time gap, that is known as chronopharmacology. You can keep an appropriate time gap so that the drug can be administered without causing any interaction, without causing any further harm. Instead, there may be a better outcome, right? And even certain drugs, so we have found that interact with certain foods. Okay, the most common example which we have studied and everyone has studied as a first example, like tetracycline with milk. Nowadays, tetracycline is very least prescribed, right? Ginseng is another one, okay, which react with the grape juice. So what is ginseng? Like all the revitalizer or immune boost natural products, ginseng, right? It's a seaweed which is there in all the immune booster or all the revitalizer. That should not be taken along with the grape juice. It has been found that it causes serious fatality as a drug interaction, right? So all these things should be checked by the clinical pharmacist and should provide a proper solution to overcome from this type of interaction. Next slide, please. Right. And how we can check this, right? How we can check this? We have various online drug interaction checkers, okay? Those are free, can be considered as a supportive tool for clinical pharmacists to identify drug-drug interaction or drug-food interaction and report them accordingly. With this service, clinical pharmacists not only enhance therapeutic outcome, but also can lay down therapeutic plan for polypharmacy condition, as well as clinical pharmacists can prepare a pre-prescription strategy for common prescription medications and their administration schedule to overcome possible drug-drug interaction. Suppose there are certain drugs which are common like paracetamol, pantoprazole, ranitidine, you can say like amoxiclav or ceftriaxone, or you can say ibuprofen, tramadol, right? So statin, as we have found in case of cardiovascular, we have found that low dose aspirin. So these are some of the drugs which are always common in the prescription. And if this type of drugs has a interaction, you can have a pre-plan and you can have a schedule for all these type of drug, how they can be administered in a particular time to avoid, to have a time gap with other drug to avoid drug interaction to improve better patient outcome. Next slide, please. Right. And the last one is drug-related problem identification and reporting. This is one of the latest situation which is been reported slowly and gradually. It's increasing. Drug-related problem or medication-related problem or medication error are considered as leading cause of therapeutic failure and one of the main reason for hospital readmission. Right. I've seen one study where it has been reported that 30% of hospital readmission cases in US is only due to medication error. It's a huge number. It's a huge number. It's a huge economic burden, as well as it's a burden on the patient itself. Yesterday, Dr. Sada has described about 5.2 million, that is 52 lakhs medication error or DRPs developed per year. But I feel this is just a tip of iceberg because many goes unreported. I'm working on this particular area of drug-related problem identification, reporting, as well as we are trying to develop a management strategy for particular drug-related problem, right? Particular drug-related problem, and so from here I can understand. Please, next slide, please, Roshan sir. Right. So there is a society that is known as Pharmaceutical Care Network of Europe, or PCNE. I'm working on their drug related problem criteria, they have given a 14 different types of DRPs that include wrong drug selection, wrong dose, wrong route of administration, wrong duration, drug duplication, drug without indication, improper drug selection, failure to receive medication, drug interactions, adverse drug reactions, right? We have seen in many cases where PAN40 as well as Rantac has been prescribed on a single prescription, right? PAN40 and Rantac has been prescribed in a single prescription. It is absolutely not required. Only one is sufficient. You did not, theoretically, you cannot prescribe both the drug. If you want to improve the situation, double the dose. If you want to say PAN40 OD is not sufficient for you, you give PAN40 BD, but you cannot add another ranitidine into a single prescription on the same day along with the PAN40, right? So another one is failure to receive medication. The patient is correct, the doctor is correct, condition is correct, drug has been written correct, but patient has not purchased, or inpatient, the drug was not given to the patient, right? So even though everything is correct, patient is not getting the outcome from the situation that the drug was not being administered. So we also can play an important part, right? It will take some time. It will take some time about this particular scenario. It will take some time, but as a clinical pharmacist who are regularly there in the hospital, observing, monitoring, analyzing case by case, should come out with this type of solutions to go and interact with the doctor to provide a better outcome. Next slide, please. Right. So the clinical pharmacist must observe, analyze, interact with the patient, and cross-match every prescription with standard reference to get the clear understanding about every drug prescribed for the patient. They must be clear and confident about every aspect of drug prescription before taking it to the notice of doctor for necessary discussion and suggestion for suitable modifications. If they can really achieve this, this is going to be a paradigm shift in the concept of pharmacy practice, and clinical pharmacists will be certainly considered as a part of healthcare team for direct patient care, right? If we really can establish our role with the drug-related problem identification, reporting, and providing a proper management criteria, we are really going to be a part in the healthcare team, not only healthcare team, we are going to be a part in the direct patient care, right? That should be our target. That should be it. It will take some time. It will have some challenges. It will have some obstruction from other healthcare problem. Nobody wants to see that someone is trying to dig up their mistake. Mistake happens by everyone, right? But if you see or if you show it as a mistake, everyone will get irritated, annoyed, or angry. Instead, you show them in a positive manner. Yes, it might have the mistake, but these are the options available through which it can be corrected, which can be improved to get a better patient outcome. Next slide, please. Fine. Now, what next? What next? This is the discussion about the 5 most common clinical pharmacy services which we can provide in the hospital to be a part as a direct patient care, or to be a part in a patient-centric model, or to be a part in the healthcare. But our discussion should be there. What is our gain? What is our gain? If we are performing all these things, what is our gain? How we can gain from this hospital training, and how we can implement all these things into the real life scenario for our profession, for our career, and for our growth, right? So I thought I'll also just briefly describe these points, like these 5 points of hospital training, these 5 particular clinical pharmacy services, how they can give you a better outcome in your professional career. As we have also themed our webinar on this particular aspect, like how we can change the direction of the profession in the pharmacy practice, in the healthcare model of India. So I just thought I'll say a few words with all of you. Clinical service is enhancing patient outcome, about how it's going to help the student, how a student can be benefited from the hospital training. In the main issue is, as there is very little or no directive or clear path. So what the students try, they try multiple choice. Whatever option is available, they are just going and trying there. Instead, I would like to request the student, I'll not advise, I'll like to request the student to focus on a specific domain regarding their profession or their career. Instead, students should aim to a particular area of their interest and understanding and progress along with the same. Next slide, please. Right. So these are some of the domains what we can correlate with our hospital training, and about these 5 particular hospital training or 5 particular clinical pharmacy services. Like clinical pharmacist in corporate hospital, I went to various corporate hospitals in Hyderabad personally. I went to Rainbow Hospital, Yashoda Hospital, I went to Sunshine, I went to even Apollo Health City, Banjara Hills. I have discussed with them. I have tried to give them even I went to Care Hospital also. We have given them a presentation that what our Pharm.D students do actually in the hospital, and they have accepted, they have agreed, and they have said, yes, we used to take pharmacists with other backgrounds or with other specialties, but we have realized that Pharm.D specialist or clinical pharmacy specialist will be a better solution for our patient care as a clinical pharmacist in the corporate hospital. There are other rules and regulation also, like if you want to have a NABH accreditation, you need to have specific number of clinical pharmacists who has to do prescription monitoring and auditing and providing service. So the student who has a zeal and enthusiasm to work in a direct patient care environment, it is suit for them. Pharmacovigilance, as I have discussed, it's a global market now. The ADR, the student who feels that I'm suitable, I'm able to understand, I'm able to analyze, provide a solution, must go into this particular domain like pharmacovigilance. Another one is medical science liaison, right? Very minimal people has the idea about this medical science liaison. Medical science liaison is a professional domain in which an individual train other healthcare professional about current and latest development of drug, device, methods, and procedure. See, the doctor, suppose a new device has introduced into the market. How the doctors will know about them? How the doctors will know about them? Sending them a webinar, sending them a flyer, sending them a mail will not have the actual outcome, right? Until there is a human touch. Until someone yesterday was asking about artificial intelligence and machine learning, right? Only sitting in front of a camera or only sitting in front of a laptop and seeing how this device works. Rather, an individual come, discuss, interact, provide information, will have more understanding. So that's the role of a medical science liaison, who will be updated with the information and will deliver the information to the other healthcare professional. Next slide, please. And the most common is clinical research associate. Whatever you have studied in your 5th year clinical research subject, whatever you have studied, same thing you have to perform in a practical manner as a clinical research associate, whatever. So if you are interested, if you are aware, if you understand, you can look into this particular domain for your, you can look into this particular domain, because the clinical pharmacists are sufficiently aware about the drug and its effect on the human being. Next one is scientific writing. Students who are well with the English, with the editing, the documentation, and capable with good English, especially with medical terminology, are best suits in this field of healthcare. Scientific writing, clinical data management, right? That's the point I said. There is another domain of clinical research where research data is managed. It is considered that until you document and manage your data, you can't establish your research. You might have done so many things, but if you are not storing your data and managing them appropriately, nobody is going to believe you. Nobody is going to believe you that you have done something appropriately. Next slide, please. Right. The scientific service in your 5th year, during the hospital project, you have prepared protocol, various forms, documentation form, and all other. So if you can find interest in that, and if you have a knack and talent on that particular, you can take that one to your profession as a scientific service, right? Students who involve thoroughly during the project work and develop the project protocol can consider this field for their professional career. Few others are also there, which is associated with the hospital training, like biostatistician, medical coding. Medical coding is nothing but to identify various medical terminologies and explain them in a broader manner. Centralized monitor, to monitor in a particular center about a new drug and its effect. Clinical data entry, as well as subject care coordinator, right? Subject care coordinator, the subject which will be recruited in a clinical trial. Someone should be there to get the patient's clear history, to provide proper information, to get the informed consent, as well as document the post-medication results and test results. So all these job or all these professional domains are also available, which are matching with these 5 most common or important clinical pharmacy service, which you can provide during your internship, or anyone can provide, whoever is going into the hospital as a clinical pharmacist, to provide patient care. Next slide, please. So this I was just going through yesterday, right? Whether is there really job on this particular field? Yes, I was surprised. Even in the month of July 2020, there is 718 clinical research jobs. So don't lose your hope. Absolutely no. There is ample of jobs. And frankly speaking, few of the points I got it from here only. I was just going through on Naukri.com, Indeed, right? LinkedIn, everywhere jobs are there. If you see the Naukri.com, it's showing like 19,696 jobs was found. I just type clinical research related jobs, the very simple keywords I have given into the Google, and this is the outcome. So jobs are also there. The only thing, please go to the next slide. Right. So never lose hope. Concentrate on the training and learning. Make your aim strong and strive hard to get that. Opportunities are available. Only you have to dig them out, right? Present day scenario, it's very competitive, very competitive. You cannot say, I have this degree, mean I'll get this job. The degree is only an eligible criteria. There will be a long list of students who has the same degree. You cannot say we all will get the same job until and unless you dig out the opportunity, you show your credit, and you strive hard to get that one. Next slide, please. With this, I would like to thank all of you for patiently listening to my discussion. This is what I have learned throughout my 16 years of student teaching learning practice from various hospitals. Basically, I am also from JSS College of Pharmacy, Ooty. I am a Ooty product. I did my master's, and I was there during the Pharm.D inception. That is a government headquarter hospital in a district. It's a small hospital. Then I was there in Coimbatore. I worked in KG Hospital. That is one of the multi-super specialty corporate hospital. Presently, I'm working in the CMR College of Pharmacy. Again, it's a government hospital, but it's a multi-super specialty medical college hospital. So I have seen variety of types in government and corporate hospital, how the expectation, what is the demand, and what we should do from ourselves. And I thought I will discuss with all of you. I hope you have gained something. If you have taken it back with you, practice, start learning, that is my success. Thank you very much, each and everyone, for participating in this 2 days scenario, 2 days webinar. And we'll share the slides. We'll obviously send the feedback, and we'll obviously send the certificates and all, right? Our technical team is on this. Neelam madam is there, Roshan sir is there. They are taking care of all this. Everything will be
Thank you,
done.
sir. I
Just be
request all the
patient.
participants. I request all the participants, if you have any questions and queries, you can type in the chat box. So you can continue.
Okay, right. Thank you very much. If you have any queries, you can please put it into the chat box. I'll try to clear them accordingly.
Sir, it was very awesome listening to you again. We had a very elaborate and your vast experience regarding this hospital, a step towards better patient outcome. You have also given us enlightenment regarding the points of better patient care and a lot of hope regarding the career for Pharm.D and pharmacy practice students. It was really awesome listening to you, sir. May I now take the opportunity of reading out the questions in the chat box?
Sure, madam. Thank you.
Yes, sir. Sir, more than queries, there are many thanks and regards that have to be conveyed to you in the chat box.
We have one query, ma'am.
Yes, I'm
The
reading out.
query is from Fatima Unisa. The question is, how a family student can implement pharmacoeconomic knowledge in clinical pharmacy service? I repeat the question, how a family student can implement pharmacoeconomic knowledge in clinical pharmacy service?
Right. Thank you. So, pharmacoeconomic model. See, if you are really in a corporate hospital, this particular concept can be applicable. That's the first thing, right? In a government hospital, the number of drugs is fixed and it is been given to the patient in a free. So the concept of pharmacoeconomic doesn't come over there. So that's the first thing. In a corporate hospital, that concept may come, but every corporate hospital will keep their profit margin at the first level, right? Today only I was seeing one like the corporate hospitals are squeezing the patient. Only if government comes out with a model of pharmacoeconomic model research, then only we can go and fit into that. Other than that, in the present scenario, I'm not seeing anything related to the pharmacoeconomic model and its research.
Yes, sir. Thank you, sir. There is one more question. Like in yesterday's session, there was a question regarding anticoagulant management service. So
Yes.
the student is asking to mail some information regarding that anticoagulant management service. The mail ID is given, sir. We will forward the mail ID to you so that the question can be answered.
Sure.
Yes, sir.
Right. INR should be observed at the first. That is the first thing. And based on the situation, whether low molecular weight heparin or high molecular weight heparin, that has to be taken into consideration. Post heparin or warfarin, post anticoagulant administration, the most important thing we have to see whether there is any bleeding or not, right? Even there may be gum bleeding also, which may not be seen. So we have to see if any such bleeding is there. If patient is within the hospital, we can have a direct care. If patient is been discharged, we have to say very clearly, don't get a prick by a pin also. If there is a pin pricking also, the blood will come like a fountain. I have seen once the junior sister get almost faint and fall. The patient was on anticoagulant and she has put the channel. As the channel has removed, the blood was coming like a fountain. The young sister was almost faint and fall seeing that situation. See the outcome. Thank you.
Yes, sir. The next question is from Sahiti Vadde. Sir, can you please suggest some areas for doing our project?
Area, see, the most important is drug utilization review. As there is so many drugs, so many, even the drug with various dose and various schedule. So we have to first see how the drugs are being utilized. Especially if you see the antibiotic stewardship, which is been most important talk in present day because of inappropriate use of antibiotic. Number of antibiotics are getting resistant. We have seen as soon as patient come, they are prescribing meropenem. That should not be. Meropenem is considered as a reserve medicine only given at the last when no other drug is been showing any effectiveness. So drug utilization review is one of the most, and the second one is any type of chronic disease, its management and outcome will be an area where we need to focus. Thank you.
Yes, so the next question is, do we have any openings in medical insurance company?
Yes, medical insurance, those medical coding, okay, as well as like as a technical service individual, whoever is sending the prescription and all other relevant document, some technical or some medical knowledgeable individual should be there in the medical insurance to understand them, to revise, to decode them and give them a brief report. So if the Pharm.D is coming forward, they will also have a better opportunity in this particular field. Thank you.
Okay, sir. The next question is, please explain about biostatistician and medical science liaison professionals.
Right. Medical science, medical service liaison. This is already there. It's not a new role. It's already there with the industries. Whenever the pharmaceutical industry launching a new product or they are coming with a new device which is they are going to market, they need to describe this one to the healthcare professionals, say to the doctors, right? Say to the doctor. Somebody should be there who are thoroughly knowledgeable, who has understanding about that particular device or the drug and has the capacity to deliver, right? Like last day also sir has discussed, I can understand, but until and unless I deliver it in a proper manner, it cannot be a complete circle, right? So that is the role of a medical science liaison. You have to deliver the concept in an appropriate manner to the healthcare professional so that they can get the point what you want to say. So you have to see the company's profit. That is the one thing. And in the biostatistician, we don't have direct biostatistic topic. BRM is there, but that doesn't give you a complete understanding to be a part as a biostatistician in the clinical research industry. I'd like to suggest if you have some small courses that you can go and join, then biostatistician you can join in the industry that has a very good scope and very beautiful improvement in the career.
Thank you, sir.
Thank you.
Sir, the next question is from Harshita Chanduri. Sir, what would be our role in healthcare sector of multinational companies?
Once again, please repeat the question.
What would be our role in healthcare sectors of multinational companies?
See, whatever the slides I have shown, all those are except the corporate hospital, all those are with the multinational companies only, right? Whether it may be a clinical research associate under a CRO, clinical research organization, IQIVA, right? They are recruiting, they are the very most, common platform for all the clinical pharmacists in present day scenario to get absorbed into the clinical research field, right? That is the one. You can get absorbed as a pharmacovigilance, you can get absorbed as a drug safety associate. So many of our seniors are there as a pharmacovigilance, as a data entry, as some of them are there as a direct clinical research associate. Some of them are there in the research. So whatever the point which I have discussed is associated with the multinational company, and we should play our role to be a career-oriented and professional role. Thank you.
Yes, sir, thank you. Sir, the next question is from Dr. Divya Amaravati. Sometimes Pharm.D theoretical knowledge doesn't necessarily correlate with the doctors prescribing guidelines. So it won't be an MRE or ME. So how do we know the level of appropriateness of a prescription?
Right, definitely. Whatever we have studied in theory, will not match always. That is obviously there. That is the first thing. There are certain situations that is known as evidence-based, right? That is known as evidence-based. The doctor has a practice duration, which during that practice duration years, throughout the years, the doctor has learned various information, various evidence for his or her practice. So even though we have studied something different in the theory, based on their evidence, they will write the medication as per their evidence support. I can say one example on this particular scenario. Like working on the orthopedics, Dr. Walia was the HOD at that time. So I was working with him on an orthopedic project for antibiotic utilization. We have asked, sir, out of 115 cases, you have only asked for like 5-6 cases for culture and sensitivity. So he told very simple, see, I'll see whether the wound is clouded, the pus is there, the redness is there, swelling, or it's hot or not. If such situations are not there, that means it has not developed any infection. Why should I waste my time to send the sample, not come back the report, and unnecessarily wait? So that's the evidence which is gathered during the practice years, and it may not match directly what we have studied into the theory.
Yes, sir. Thank
Thank you.
Sir, the next question is from Mohammed Wazir. Sir, can you say about reporting a case that is already existing, but want to report to aware about the case situation and the number of cases present? Do you want me to repeat?
Once again, repeat.
Yeah.
Yeah.
Sir, can you say about reporting a case that is already existing, but want to report to aware about the case situation and the number of cases present?
Yeah, definitely. The case which was already published or reported by somewhere was there from some other places, right? So if you have seen something again in your place, generally, if it is only rare or if it is of a case of learning, then you must report it again so that it can create awareness amongst other healthcare professionals. So it is suggested, and it is also important that we understand and we report such cases. Yes. Thank you.
Yes, sir. Thank you. Sir, the next question is from Sumalata. Does it cause any damage by long-term usage of insulin injection in case of patients undergoing cardiac surgery?
Long-term insulin injection. See, directly insulin may not cause any effect, right? But the situation may be there. There are certain situations whenever there is a injectable product, product for long-term use, some associated complications are also there, like thrombophlebitis, infection at the site of injection, or there may be like necrosis formation, or even there may be pain and swelling if inappropriately injection has been administered. Other than that, I didn't see any such a report where insulin is related to the cardiovascular surgery. No, I don't see any such. I haven't seen any such a report previously. If anything is there, it's beyond my knowledge. I can't say on that. Thank you.
Yes, sir. Thank you. Thank you for answering all the questions. Sir, may I now request if any faculty is interested to speak, or we can move on with the session?
Yeah, ma'am, you
Yes,
can
sir.
continue the session.
Okay, sir. Thank you. May I now request our principal, Dr. K. Abulu Garu, to speak on this occasion?
Yeah, good morning, everyone, all the participants and faculty members, and also the organizers. The session has come to an end, and I thank our faculty, Mr. Sushant Kumar Das, for elaborate information on this pharmacy practice, basically hospital-related activities. Thank you very much, sir. You spoke on hospital training activities. clerkship project and guidelines, internship, and also the patient counseling and drug information services, ADR monitoring, and the future prospects of this pharmacy practice. So you have given our participants very good information. I hope the participants might have got the answers for their queries. And even yesterday also, Dr. Shatagopan sir has given a very good lecture on this clinical pharmacy services and overview. He touched upon this pharmacy practice in India and its goals, healthcare system, how it is related, and healthcare services in India and the gaps, and the clinical pharmacy services and need-based education. On these topics, he has given very good information. I think even by seeing the interactive session yesterday, there were several questions related to this clinical pharmacy services. Really, I thought, I think people might have been benefited from this, and we tried our best to disseminate the information through our resource persons. And if at all any deficiencies are there, you can give us in the feedback so that for the next time we will go with the uh, the corrections and etc. So in an effective manner. So I thank you everyone, all the participants, and I thank even the organizing committee of CMR College of Pharmacy and also Pharm.D department to come out with this this 2-day webinar on the pharmacy practice uh, drifts. And I wish you all the best. And now it is over to again Chandana madam to continue the further proceedings.
Thank you, sir. Thank you very much. May I now request Mrs. Neelam Shetty, Department of Pharm.D, to give the vote of thanks.
Yeah, thank you, madam. Thanks so much. Roshan sir, can you please share the screen? Yeah. It's my privilege to have been asked to propose a vote of thanks on this occasion. I, Neelam Injeti, on behalf of CMR College of Pharmacy, Department of Pharmacy Practice, Pharm.D, extend a very hearty vote of thanks to all the honorable delegates who blessed us with their presence and took out valuable time in spite of their busy schedule and in this pandemic situations. Thank you, one and all. I wish to express my gratitude to our Secretary Correspondent, Sri C.H. Gopal Reddy Garu, for providing encouragement and support for this webinar. I would like to extend a special thanks to Dr. K. Abulu, Principal Sir, CMR College of Pharmacy, inspiring us to make this webinar happen. Thank you, sir. And at the outset, we had this 2-day webinar titled Present Day Drift in Pharmacy Practice, 6th and 7th July. That was yesterday and today. Our day one speaker, Dr. G.K. Sadagopan, sir. I especially like to thank you, sir, which was very valuable speech, where he has mentioned about all the real-time problems faced by the clinical pharmacist with very good examples, and also has explained us how to rule out them and how to work effectively. And the way he explained the topic about the clinical pharmacy services was exemplary. Besides him, I would also love to make a special note on today's speaker, Mr. Sushant Kumar Das, sir, for his for sharing all his experiences, knowledge, and guidance, which was very much enlightening and encouraging. Thank you very much, sir. I hope all the doubts of all the delegates have been clarified in rationale. I'm very grateful to, and I would like to, I would like to give the report of yesterday session. We had a total of 709 registrants. It was a very great number. And among them, we had a total of 349 participants, unique participants in the yesterday's session. And we had even a YouTube channel in which 280 people have viewed it and subscribed it, and I really appreciate this count. Thank you all the delegates, student delegates and faculty delegates for your extensive participation. Thank you all. I'm very much grateful to our HODs, Dr. Ram Mohan sir, head of pharmaceutics, head of pharmaceutical chemistry, Dr. Sharada, head of pharmacognosy, Dr. Kiran Kumar, head of pharmacology, Dr. Uttam Panigraha, head of pharmaceutical analysis, Dr. Saujanya Bhattu, head of pharmaceutics, for their extensive support in organizing this event. Thank you, one and all. I add a special note to all the committee members who have worked earnestly to make this webinar a great success. The registration committee members, Mr. Siddhappa sir, Dr. Ramya ma'am, Miss Mary Swarnalatha ma'am, Dr. Khadir from registration team, scientific team, Dr. Abulu sir, Dr. Ram Mohan Reddy sir, Dr. Sharada ma'am, Dr. Kiran sir, Dr. Uttam sir, and Dr. Saujanya ma'am. Thank you all. Technical team, Dr. Raghavendra sir, Mr. Roshan Ali, and Dr. Srinivas sir. Thank you all. And the certificate committee, Ms. Pavni ma'am and Mrinali ma'am, thank you all for your extensive participation. And our moderators, also thank you, madam, for your support. Please accept our deepest thanks, Mr. Roshan Ali sir and the technical team for making this webinar a great success without any hitch. I mention my deep appreciation to Dr. Chandana Kamali ma'am for hosting this webinar in an amazing manner. Thank you, ma'am. Thank you so much. I extend my heartfelt thanks to our today's second day speaker, Mr. Sushant Kumar Das, in charge of Pharm.D, CMR College of Pharmacy, for putting the seed for conducting this webinar and happening this in a great way. Thank you, sir. Thank you so much. As this is my team member, as no program can become successful with a single person, so I extend my big thanks to our department Pharm.D team for their support, and also the volunteers, which includes especially our Pharm.D 50 students of CMRCP who have helped me in making the flyer and helping in a few of the technical issues. Thank you, students. Thank you guys for making this event a success with your contributions. Last but not the least, as the count speaks the success of the webinar, I would extend my heartfelt thanks to the student and the faculty delegates who have registered and participated in this webinar, in this two-day webinar, and enthusiastically involved in all the presentations and giving out all your queries and helping us to make this webinar a very success. Thank you all. Thank you so much.
Ma'am, you can tell about the certificates.
Certificates, yeah. Yesterday, feedback form was given to 349 people who were present for the yesterday's seminar and yesterday's webinar. And today's webinar participants also will be given the feedback link. And people who have attended both the webinars only will be given the certificate, e-certificate. So kindly make this note, because most of them are keeping on texting those who have registered. But please, both the sessions who have attended only will be given the e-certificate. Thank you. And it may, as the count is very high, it's around 700. So it may take time for, to send the certificates or to reach the certificates to you. So give us a time of around 5 to 6 days to send all the e-certificates. Thank you all. Thank you all, especially the faculty delegates who have actively participated in this and given your efforts. Thank you. Thank you, one and all.
Thank you, ma'am. And thank you all the participants for participating in the two-day webinar. I thank the moderators and all the committee members. Thank you all and wish you a good day and stay home with a safe seat.
Thank you, sir.
All.
Very awesome listening to you all. I request all the participants to stay connected with us with CMR College of Pharmacy. We'll be coming up with more programs in future, and you please be connected with us on our YouTube channel, and we'll be coming up soon with our college radio also. May I request all the participants to join us with the same enthusiasm and make all our programs a grand success. And thank you all for this successful event. Thank you.
Thank you.
Thank you.